Hi, my name is Adanma Ayanambakkam. I'm a genitourinary medical oncologist and an assistant professor at the University of Oklahoma at Stephenson Cancer Center in Oklahoma City. We have a cohort of patients who have upper tract urothelial carcinoma, and we did a retrospective multi-institutional analysis of looking at how MRD testing with Signatera or tissue-informed ctDNA correlates with recurrence-free survival in this cohort of patients. So upper tract urothelial carcinoma has historically been a more aggressive subtype of urothelial carcinoma, accounts for about 5 to 10%. It's been difficult to treat this because we don't have a biomarker that's been able to guide treatment options, and they vary in terms of treatment outcomes. So our purpose of this project was to try to find out if we could identify a biomarker that can be easily used in clinic to identify those patients who are at high risk or low risk in terms of urothelial carcinoma. So the primary objective was to figure out if MRD-based tumor DNA testing to identify MRD or molecular residual disease is important in terms of predicting recurrence-free survival. Our secondary objective was to look at MRD testing and see if there was an ctDNA correlation with radiographic recurrence. We had about 45 patients with about 396 samples in this cohort of retrospective upper tract urothelial across multiple institutions. So what we found in this analysis was that we found that we defined two different endpoints. We defined post-operative endpoints as MRD window or molecular residual disease window, defined as 2 to 16 weeks after surgery or before initiation of adjuvant treatment, and the surveillance window, which was defined as more than 16 weeks after surgery or after completion of any adjuvant treatment. And what we found was that ctDNA positivity at either of these time points, either at MRD window or in the surveillance window, was associated with a higher risk of disease recurrence or recurrence-free survival, with a hazard ratio of about 18 and 14 respectively in these two cohorts, with a statistical significant p-value of less than 0.05. I think it's a little bit early to make clinical decisions based on this, but it's definitely supportive. It's telling us that if we're able to use ctDNA either in the MRD window or in the surveillance window, we can identify those patients who have a higher risk of recurrence or a lower risk of recurrence accordingly. We did do a multivariate analysis to try to look at ctDNA and if there was an interaction of ctDNA versus all the other histopathological parameters that we've used, like grade, stage of disease, and so on. And even in that multivariate analysis, what was positive was ctDNA positivity at any time point, either at the MRD window or the surveillance window. So in a setting where we don't have a lot of biomarkers to help guide treatment options in the adjuvant setting, and when we have a varying degree of recurrence risk, I think this could be potentially groundbreaking in terms of telling us who those patients who need aggressive treatment are and who those patients who can potentially go on a surveillance or a de-escalation of treatment opportunities are.